Dodie Trimble is now going to talk to us about linking data to support quality agenda. Now, Dodie is an old hand at HOBIC because she was one of our original regional coordinators. We seconded her from Simcoe, and then they insisted that we give her back. So, Dodie.
Perfect, thank you. Are you going to work that thing for me then? Perfect. So I'm just a little ways down the road from Diane. We're on Lake Erie. We're down near. Now I know you'll all know where I come from when I say that the bikers on Friday 13th drive by our door on their way to Port Dover for the day. So Friday the 13th, needless to say, we beef up the ED, and we have the presence of our police on hand. So it's quite, you feel like a parade. I drive from Hamilton to Port Dover, so I feel like I'm in a freaking parade on the way down Highway 6 with the bikers. Quite safe though, they're very nice folks. Anyway, I have been with HOBIC for a little while. I can't say, like Diane, that our completion rates, we still struggle with those, and I see some nods, so I don't feel so bad saying that this afternoon. As I was looking at what to speak to you about, just to give a little bit of what we're doing in Norfolk General around quality, I looked at, maybe the most recent things that really are on our minds and on our plates, and then it wasn't after till I got here and I read the topics of the presenters, I realized, oh, I'm talking about senior friendly, and I'm talking about COPD, CHF, and I'm talking about transitions in care. So really, my job is your job and your job is my job. It's all about quality and it's all about outcomes. So, oh, he did give this. What do I push?
Green arrow.
The green arrow. The big one. Here we go. So, one of the quality jobs that we're doing right now, because of the provincial focus on a senior-friendly environment, and Diane just told you the impact that seniors are going to have in our acute care beds in the future, and it's going to be very similar for all of us. So we look at the provincial priorities, the LHIN priorities, and we know that 75% of the patients in our inpatient beds are seniors, and that is probably common with everyone. So when I look at quality and the use of the HOBIC measures, it just makes sense to look at how can we support, either improve or sustain independence, and how do we measure that? How do we look at that? How do we get our care providers at the front line to look at that? The HOBIC measures very clearly give it to us so easy around activities of daily living. Let's look at that. Let's measure that. Let's look at also therapeutic self-care keeps coming up. I didn't realize the value of therapeutic self-care until I dropped into this role around quality, and it comes up in so many different questionnaires or on the agendas of every single service in our organization around what do patients know, what do they tell us. When I first started with HOBIC, there was a student that was working with us, and she had a statement that she was saying to her RPN students, and it is, and her student, the statement comes from one of her favorite nursing leaders, which was Hildegard Papelo, who says, "It isn't what you know, it's what you do with what you know." And how many times that comes up? I know this, but what am I going to do with it? And we're seeing, as we talk that way, our nurses are able to be those participants with us. Not just our nurses, because we're all looking at interdisciplinary practice. So everybody needs to keep that in mind. What are we doing with what it is we know? We, very common to that, and that functional status is move on. Organizations are looking at how do we keep our patients moving. They don't just come in and get into a bed and stay there for 3 weeks and then go home. We have to keep them moving, and I know there are help programs and move on initiatives, and to maintain the status of our patients. So when I look at it overall, on the quality agenda around what are we doing so that these patients hopefully can go home, if we can get them there, what can we do to help sustain their where they are or where they want to be? And that really links into patient-centered care. What is it that our patients want? How can we support where they want to be? The HOBIC measures give us an idea. On admission, at least we have a running chance. Sometimes our patients aren't with us very long. We have a running chance if we can at least see something and do that proper assessment and look at those ADLs, the simple symptom management, and therapeutic self-care is huge. Supporting Aging at Home initiative, where we are all looking at making sure that we're doing the very best to support our patients to return to home if with the supports in the community. Therapeutic self-care, it's a great way also for us to start those discussions, not just with our patients and their families, and but with the community. Where we end is where you start, and how can we share that and talk about that? And it was interesting to hear you talking about congestive heart failure, because that too is on our agenda right now. We're looking at, and I had a meeting with our late career nurses who are involved in this on Tuesday afternoon, and as they're going through, they've done some chart reviews. We know it's our top CMG, so they've done the chart reviews, and they were so excited to be a part of that, having the time to be able to do those chart reviews, and so they did they did 40 chart reviews. We're a little bit bigger, we're only 120 beds, but they did the 40 chart reviews. And then as they were talking with me, they were saying, but you know what? The therapeutic self-care and the HOBIC, if that had been done, how much more could we have done, or at least thought of? It's what we could have done had we known. So the importance is, they said it to me, I had to get back up on my chair after they said it, but having the frontline staff identifying that these are really important things for them to know in order to really feel that they're providing the best care possible for their patients throughout that stay. And we're looking at that trajectory going on to the next level of care as well. Reducing falls, we've all been there, done that. I think we're getting tired of talking about falls and fall strategies, and it seems to be going down the list when you look at anybody's quality improvement plans, fewer and fewer, because we've put those things into place. But we still need to make sure it doesn't just drop off our radar. We have to continue to talk about fall strategies. So it's truly important. We should be able to see that falls is a part of our assessment on admission, and usually we go beyond, we go beyond the HOBIC, but all of this information can pull together to identify that your story that you're telling is truly what's happening in your organization. And I did mention client-centered care. It is on everybody's agenda. Accreditation, we just went through this in March. Oh my goodness, that's almost a year ago, so crap, we're gonna have to start getting our groups together again. Mind you, I did find out this morning that we've been given an extension of a year because we're accredited with exemplary standing, so we're happy to see that. Makes the finance people happy because they're gonna save a few dollars there, so that's okay. In accreditation, of course, you know all those real special ROPs, and it's amazing when you start going through the ROPs and the standards for the various services, how issues around activities of daily living and therapeutic self-care, they just keep coming up. So the information is embedded in so much of what we already do. So, and medication reconciliation, I know there is a process for that. Where we were finding we were falling short, we knew what we were doing, but what did the patient know about what we were doing? So in that therapeutic self-care, it pulls you back. Take a look. What are they saying they know about their meds? We can say, oh yeah, they know about them. What do they say they know about their meds? Interestingly enough, you can compare, now the HOBIC data is in real time, a big plus for HOBIC data. You can compare that to your NRC picker too, because if any of you've read the questions, the actual questions that are sent out in the surveys, there's questions in there about medications. So it's coming back, and you can link that together to say, yeah, now we know NRC picker's a little bit longer coming back to us, but it is over time. Those of us who've been doing it for a long time, you can see the value in linking those pieces of information. This isn't rocket science. It's important for us to know. Fall strategy, again, as I said, it is an ROP. It is required for us to truly show that, but you can use the information that you've got in your patient's charts as you have reflected back on. Real time is your HOBIC data that you're completing, along with if you're using a scale of some form. But all of those together start to give good information that the surveyors are hearing from you and from your staff in various ways. The same thing is being said, and it starts to, they get it, that it isn't just coming from one report, it's what we did with what we knew. The focus in the quality plan, definitely in your quality plans, there is, you need to have information in there that shows information about your patient. What is your patient saying? So I know our quality plan, we really had to do some work on our framework and when it came to accreditation, but we were able to identify within that quality plan what we were measuring, and the HOBIC information, the HOBIC measures are within the quality plan. So as you pull out your own quality frameworks when you go back to work tomorrow, I know you'll all go right and pull those out, there is other information you can put in there that identifies the picture is starting to come together. The quality blanket that you're weaving in your organization is all starting to come together. And HOBIC fits in there extremely well. Patient experience, I know that patient experience is usually captured by our surveyors as they go and they talk with the patients. You want the patients to know that somebody has talked to them about what's important to them, and that's client-centered care, and that's talking to them about their symptoms, giving them information about their symptoms, talking to them about therapeutic self-care, making sure they know what their symptoms are, when to call somebody, do you know who to call? All of those are extremely important in the whole picture for the patient. And the surveyors could hear that from our patients in the accreditation process. And of course, the safety practices, having those in place, and I know that they're in the ROPs listed, pressure ulcers are there, falls are there. Those are also identified in your HOBIC measures. I know you all want to get back and work on your accreditation stuff now, don't you? And the quality plan, just being a significant part of my portfolio and looking at quality improvement plan and involving as many as we can in our quality improvement plan. It's going to be our path for the next year, and often it takes a couple of years to really see a difference, and you put those into your plan, and then, oh, you don't quite reach it, but you need to keep on measuring. And in the quality improvement plan, really integration is a new quality dimension that has been added by Health Quality Ontario. And transitions in care really can identify how are you linking with and integrating the plan for this patient. It goes beyond your walls. So partnering with our CCAC partners and looking at, and we've partnered with them in a couple here. We're looking at congestive heart failure right now and the transitions in care, functional status, therapeutic self-care, so that when our patients go beyond our walls, that information is there, and we're really encouraging then our CCAC partners to make sure that we get that information back if the patient is one of those 30-day readmits, which is right next. Chronic disease management is what we're looking at with our CCAC partners as well. Congestive heart failure is the topic that we've looked at, and when you look at the self-care and for our patients, in that 30-day readmission, we're hoping that we'll be able to drill down and find some and you're probably going to find it, Diane. There are some things that we're falling down on, and why is that so? So in your quality improvement plan, you can certainly build in the HOBIC measures. Reducing unnecessary acute care days, so your ALCs, so functional status, having a true focus on functional status for our patients. Needless to say, that should be for all of our patients, because we want to reduce VTE as well. So you want the move on, the functional status. You have to know what you're starting with so that you have an idea where you're ending up. Therapeutic self-care, again, supporting our patients so that they can be at the best level they possibly can, using whatever programs you're introducing, your HELP program, Move On program, and then, of course, supporting the Home First philosophy for our patients. And client experience, needless to say, that is a huge part of quality improvement plans, looking at pain and pain assessment. The therapeutic self-care, it sounds like I'm repeating myself again and again, but it really, when you start looking at where can you use that in your quality agenda, pulling that information, the more people that are using it, the more people are aware of it, and it is hugely important to our patient population. And of course, our fall strategy. And I think that's the end. It is.
Hi, my name is Sarah. I work at the ministry, and it's actually really great to see this, your little presentation. I appreciate it because I predominantly work around hospital quality improvement plans, around ECFA and that kind of thing. And I'm just wondering if you can expand at all. You mentioned a little bit about using HOBIC data to kind of support some of the priorities in your quality improvement plans, but I'm just wondering if you can get into a little bit more about that. Are you kind of sharing, do you find it useful to share data maybe with your staff to kind of see how you're moving towards your goals?
Right. I think that a lot of organizations are using NRC Picker a fair bit in their quality improvement plans. And so an example for us is when I looked at what our NRC Picker was saying around those questions related to therapeutic self-care, very similar to what HOBIC was saying. The difference being HOBIC is now, NRC Picker is 6 months later. So I have a running chance today to make a difference, whereas, we're always going backwards, and that's okay. That drives quality too, to go to the end and work back. But HOBIC gives us a chance to start today and have a difference before the patient leaves our care. So we can, I looked at that, and it was, it really wasn't a sell job, but when staff realized the information is coming back to the leadership and to them, we share our surveys with them, with the board, We know this already. If we have a running chance to make a difference, then let's start, a couple months earlier when the patient is actually with us and look at those and how can we make a difference then when it comes to what do they know, who do they call, what are their symptoms, all of those questions that are certainly indicative of self-care. That's just one example of how we can use the HOBIC measures because it is real time. Did I answer? Is that going to help? Yep. Nope.
Any other questions for, yes, Kevin? Yeah.
A question about whether you stratify your patients and match your interventions to the characteristic of your patient groups, because like Diane's program as well, with some of these CHF or COPD patients, they're so diverse. So how do you match some of your interventions or your nursing interventions particularly to that population based on the
I'll probably
severity?
be able to answer that really well in a couple of months, I would think. The reason I say that is that we looked at the top CMGs, and I was going to guess for our organization it would be COPD. And then when our health records helped to clarify that for me. No, CHF is our top CMG around, I have to clarify, that's the 30-day readmits, because we're looking specifically at that for a quality improvement plan. So now with the Late Career Initiative and having our nurses doing the work and having them look into the chart, pull the chart, read through the charts, find out what it is, really dig into the chart, look at what is best practice, compare what we're doing, and looking at our data to see. So we'll know better which of those therapeutic self-care we're falling through the cracks on, so that we can match it to that patient population. I'm trusting that the next group we'll go to will be, because they said to me, well, we should be doing this for COPD. Sure we should. So that will be our next group that we go to. So we will be able to do that. We too are a small organization, and we would probably be looking at this, doing this as by hand, chart reviews, that kind of thing. So as we get more techie, we'll be better to have that on our fingertips. But I think we're right at the very start of this. Yeah.
And you probably aren't thinking to yourself when you're doing that, now I'm going to stratify the patients. That's a very nice research kind of thing.
Yeah.
But in terms of grouping the patients
Yes.
into those that are in, are at this level in terms of some HOBIC scores on admission.
Yeah.
And maybe some other experiences that the nurses are bringing to that as
Right.
well in terms of
Yeah.
their experience of the patient.
Yeah, yeah.
So,
And it is exciting to see the nurses at the front line are doing this and involving the OTs and the PTs, and now we have a team. So the measures are being looked at by more and more people.
Which is another asset around HOBIC, because, you're going that way, because they're generic. They're generic not only in terms of patients, but we know that while they reflect nurses' contribution to patient care, they reflect other disciplines' contributions, so they're of value to all of the disciplines. And I think that perhaps more than some nurse-developed, nurse-specific measures, some out there, that there's more receptivity to these measures that reflect all of the contributions. Okay, thank you, Dodie.